Hello. So today we'll be discussing about the rhythmical excitation of the heart. In this, mainly we'll be discussing how the SA node is able to generate the rhythm automatically, or how is there an autorhythmicity in the heart and the intrinsic conducting system of the heart. Autorhythmicity was also known as self-excitation, or the ability of the SA node to generate action potentials or rhythms without any external influence. So starting with that, this is the excitatory and the conductive system of the heart. So there is an SA node. SA node is connected to the AV node via the internodal pathways. The AV node then branches into the via the AV bundle fibers into the left bundle branch and the right bundle branch, and then they supply the muscles of the ventricle, which is the Purkinje fiber supply the muscles of the ventricle. So before we go into how the SA node is able to generate the action potentials on its own, we will first see how action potential is generated in the cardiac muscle, especially the ventricle. So you can see the phases of the action potential of the cardiac muscle here, or the ventricle. So there is phase 0, which is the depolarization. Then there is phase 1, which is the initial repolarization. Phase 2 is plateau. Phase 3 is the rapid repolarization. And then phase 4 is the resting membrane potential, which is between minus 90 to minus 80 millivolts, around minus 85 millivolts. So what would be the difference in the generation of action potential in the cardiac muscle as compared to the skeletal muscle? The most important would be the presence of L-type calcium channels. The voltage gated fast sodium channels and the potassium channels are also present in the skeletal muscle, but L-type calcium channels are not. At rest, at the resting membrane potential in the sodium channels, the activation gate is closed and the inactivation gate is opened. There are two gates in the sodium channels, voltage gated sodium channels. Inactivation gate is open and the activation gate is closed at rest. Whenever there is depolarization, the depolarization, when it crosses the threshold, it gives a stimulus to the gates so that the activation gate is open and the inactivation gate is closed. So activation gate opens, inactivation gate is closed. Both of this will happen because of the depolarization, but the closure of the inactivation gate is slower. So immediately for a few milliseconds, this will open, and within a few milliseconds, the inactivation gate will close because of the stimulus of depolarization. The same depolarization stimulus will open the potassium channels also. So the voltage gated calcium channels, the activation gate opened. For a few milliseconds, the sodium is influxing. So there is influx of sodium. Then the inactivation gate closed. So now the sodium cannot come inside. The same stimulus opens the potassium channels. Now the potassium starts going outside the efflux, and which leads to repolarization. In the cardiac muscle, what happens is the voltage gated fast sodium channels open, lead to a depolarization, rapid depolarization, which is the phase 0, and then they close abruptly within a few milliseconds. So because of the inactivation gate, so there is initial repolarization, which is the action potential starts coming down. But the L-type calcium channels also open, but they're slow to open. So within that much time, the L-type calcium channels, low calcium or the calcium sodium channels open, and they remain open for about 200 milliseconds. The influx of calcium will lead to maintenance of the plateau, and there is decreased permeability of the potassium also. At the same time, the potassium channels close because there is decreased permeability of the potassium because of the excess calcium. So there is a plateau in calcium is influxing, and there is slow efflux of potassium outside. So there is a plateau phase, and then after about 200 milliseconds, the calcium channels also close, the potassium channels open, because now there is no excess calcium influx, which is decreasing the permeability. The permeability of the potassium increases again. There is increased potassium efflux, bringing the action potential back to the resting membrane potential. Bringing the membrane potential back to the resting membrane potential. Clear? See, so revising it, phase 0 depolarization is because fast sodium channels open. The phase 1 initial repolarization, the fast sodium channels close, the inactivation gates closed. Then the plateau is because of the open calcium channels and the fast potassium channels close, or there is decreased permeability of the potassium. After about 200 milliseconds in phase 3, the rapid repolarization phase, the calcium channels close and the potassium channels are open, and there is a flux of potassium. And the phase 4 is resting membrane potential, which is about minus 85 millivolt. So this is the same diagram, but with the current graph on the below. So there is in the phase 0, there is increased inward current of sodium, which you can see, and in phase 2 there is increased calcium current, but the outward potassium current has decreased. So the outward potassium current has decreased during the period when the calcium is open because of the increased calcium influx. Then when the calcium gets closed, or the calcium channels closed, then the potassium outward current increases back, bringing the membrane potential back to the resting membrane potential. So this is how the action potential is generated in the cardiac muscle. This is the refractory period. So refractory period is any in the period of time in which a new impulse which comes will not be able to generate another action potential, or the cardiac musculature is refractory to any new impulses during that period. Absolute refractory period will be similar to the time in which the plateau phase is there, which is about 200 to 300 milliseconds in the ventricles. In the atria, it is slightly smaller, it is 150 milliseconds. Relative refractory period is the period in which if a stimulus of more than normal strength comes, then it will be able to stimulate the cardiac muscle, or it will be able to generate an action potential. But the major thing which we can notice here is if there is an early premature contraction when the supramaximal stimulus comes in the relative refractory period, the strength of contraction is lesser than the strength of contraction which is normally there, which is different than what happens in a skeletal muscle. In a skeletal muscle, there would be a summation because of residual calcium, but in heart or the cardiac muscle, the early premature contraction leads to decreased force of contraction, because partly due to Frank-Starling law, if there is decreased time for the cardiac muscle to relax, there will be decreased end diastolic volume, and decreased end diastolic volume will lead to decreased preload, decreased force of contraction. So there is, if an early premature contraction happens, there will be a decreased force of contraction. Here we can see a later premature contraction. So now we have seen how an action potential is generated in a cardiac muscle or a ventricle. Now, how is it different from the action potential that is generated in the SA node, and what makes the SA node self-exciting? So SA node is a strip of specialized cardiac muscle which has no contractile muscle filaments. Almost no contractile muscle filaments are present in the SA node. So SA node and all the special conducting and excitable and the conducting system which we'll be discussing in this lecture would be non-contractile. They will be mainly for the purpose of stimulation or the excitation, which is self-excitation, or the conduction of that impulse to different parts of the heart. So these are non-contractile muscle filaments, and these are very small. So 3 to 5 micron in diameter fibers, which is much more smaller than the atrial muscle fibers, which is 10 to 15 microns. So these are the nodal fibers, which are 3 mm wide, 15 mm long, and 1 mm thick strip of cardiac muscle, which is present in the superior posterior lateral wall of the right atrium. The location is very important. The superior posterior lateral wall of the right atrium, it is present, which is below and lateral to the opening of the superior vena cava. So this is the SA. So how is autorhythmicity of the SA node occurring? So this is the resting membrane potential, or sometimes it is known as the restless membrane potential, which is from -40 to -60 millivolts. So what happens is there is leaky currents, leaky sodium and calcium channels which are present in the SA node. These leaky channels will allow funny current, which is the influx of sodium, to occur continuously. Whenever sodium is in, there is influx of sodium, the membrane potential will become more and more positive. So whenever the threshold of discharge is reached, -40 millivolts, L-type calcium channels open. These L-type calcium channels will lead to a generation of action potential, which is slow to occur, and then it is slow to repolarize also because of the opening of potassium channels, and the potassium channels will lead to repolarization, and as soon as the repolarization is complete, then again the potassium channels close because the potassium channels remain open for only a few milliseconds. Whenever the potassium channels close, then again the funny currents will be there to increase sodium influx, will lead to increase in the membrane potential. As soon as it reaches the threshold, again the same cycle happens. So this is how rhythmical discharge is taking place, and this is the ventricular muscle fiber action potential which we already saw. Because of the SA node generation, after that SA nodal action potential is transmitted to the ventricular muscle fiber, then ventricular muscle fiber will also generate an action potential which will look something like that. The resting membrane potential would be about minus 85 millivolts. So in SA node, the RMP, resting membrane potential, would be minus 55 to minus 60. There are leaky currents of sodium and calcium in the cell membrane of the SA node, which is known as the funny current. And most important thing would be that the fast sodium channels are already inactivated, because at this resting membrane potential, or at this level of membrane potential, the sodium channels, the activation gate was already open, and the inactivation gate stimulus for closure was already present. So now the fast sodium channels are present in an inactivated state in which the activation gate is open but the inactivation gate is closed. So the fast sodium channels do not take part in the generation of action potential in SA node. It would be mainly because of the leaky current in this phase and L-type calcium channels after the threshold is reached. So when potential reaches minus 40, threshold of activation of L-type channels is crossed, L-type calcium channels get activated, and then they will get inactivated after about 100 to 150 milliseconds. So see, this is the same as the refractory period of atrial muscles. So refractory period for atrial would be about 150 milliseconds, because that is the time in which the L-type calcium channels get closed in the atria, and about 200 to 300 in the ventricular musculature. Then the potassium channels will open and remain open for a few hundred milliseconds, and then they will close again, leading to increased leaky discharge of sodium and calcium, which is present always, but the potassium will dominate if the potassium channels are open. When the potassium channels close, then the cycle of the action potential generation can resume again. So this is how autorhythmicity of the SA node is there. So whenever SA node, rhythmically it is discharging about 70 to 80 beats per minute, so that impulse, the action potential which is generated here, that impulse will travel via the internodal pathway in the anterior wall of the right atrium, the lateral wall, and the posterior wall, and they are known as anterior, middle, and posterior internodal pathways. So these three pathways will lead to the impulse transmission from the SA node to AV node. From AV node, there will be AV bundle, which is also known as bundle of His, which will transmit the impulses to the ventricles via the Purkinje fiber. This bundle of His will divide into left bundle branch and the right bundle branch, and then the Purkinje fibers will then go on to innervate the ventricular musculature. Also, from the SA node, there are fibers which are going from the right atrium to the left atrium. These are known as anterior interatrial pathway, or the Bachmann's bundle. So the anterior interatrial pathway, or the Bachmann's bundle, will connect the right atrium to the left atrium so that the impulse can be transmitted there. So this is the excitatory and the conducting system of the heart. Now, the most important thing would be the velocity of conduction in all these fibers. The velocity of conduction, atrial muscle, the musculature, is 0.3 meter per second. So in the SA node, whenever the impulse is generated, then the SA node fibers are connected to the atrial fibers. So whenever any impulse is generated in the SA node, that will lead to stimulation of the atrial musculature fibers, and because of the interconnections in the atrial muscle, the conduction will happen at the rate of 0.3 meter per second because of the gap junctions which are present. So it makes an atrial sensation. Ventricular muscle fibers are slightly larger than the atrial fibers, and the velocity of conduction would be 0.3 to 0.5 meter per second. The internodal pathways, the Purkinje fibers, are specialized conduction fibers. These are present only for the purpose of conduction. See, atrial and the ventricular musculature will have contractile fibers, but internodal pathways and the Purkinje fibers do not have contractile fibers or muscle filaments. Just like the SA node, they are for the process of conduction of impulse from one part of the heart to the other. So the speed of conduction is, an internodal pathway is 1 meter per second, and in Purkinje it is the fastest, which is 1.5 to 4 meter per second, because they are even larger than the ventricular muscle fibers. One. Second, the gap junctions of the Purkinje fibers which are present at the interconnected disc in between consecutive cells have a very high permeability of ions. So because of the very high permeability of gap junctions at the interconnected discs, The Purkinje fibers conduct the impulses at a very fast rate, and the AV node conduct the impulses at a very slow rate, the slowest, which is 0.05 meter per second, because of the diminished number of gap junctions. We will see the importance of the AV node conduction velocity. Why is it very slow? So because of the diminished number of gap junctions between successive cells, the AV nodal cells will transmit impulses at a very slow speed of 0.05 meter per second. So coming into the AV nodal, so the internodal pathways, the anterior, middle and the posterior internodal pathways via the transitional fibers will go into the AV node, and from the AV node there will be a penetrating portion of the AV bundle, which is the bundle of His, which will penetrate the atrioventricular fibrous tissue. And then there will be a distal portion of the AV bundle. The distal portion of the AV bundle of His dividing into left bundle branch, right bundle branch, and then the Purkinje fibers will go on to spread into the ventricles and supply the ventricular musculature. So the AV nodal delay is because of the diminished number of gap junctions which are present in the AV node. So the impulse starting from the SA node, if we take the point as 0, the impulse will take 0.03 seconds to reach the AV node via the internodal pathways and the transitional fibers. Then it will take about 0.09 seconds, about 0.1 seconds it will take in the AV node itself. So that is known as the AV nodal delay. So then again 0.04 seconds will be taken for the impulse to travel from AV node to the bundle branches. So about 0.13 seconds are consumed or taken for the impulse to travel from the transitional fibers to the bundle branches. This is the AV nodal delay. Another property of AV node would be one-way conduction. There is inability of the action potentials to travel backward. So the action potential can travel only in one direction from the atria to the ventricles. Third, there is an atrioventricular fibrous tissue which acts as an insulator between the atria and the ventricle. So no impulse can be conducted from the atria to the ventricular via this atrioventricular fibrous tissue. So the only pathway via which the impulses can travel from the atria to the ventricular is via the AV node, which is the penetrating portion of the AV bundle and then the distal portion. So this allows the atria to contract first. Then after a delay of about 0.1 seconds, the ventricles will contract. So that 1.1 to 0.12 seconds. So that delay is required so that the atria can contract fully and then empty their blood into the ventricles, and then the ventricles will start contracting and then they will empty the blood into the aorta or the pulmonary artery. So this is the AV nodal delay allows the atria to empty their blood into the ventricles before the ventricular contraction begins. So then after it reaches the right and left bundle branches. So the distal portion of the AV bundle divides into the right and left bundle branches after about 5 to 15 millimeter in the septum, descending into the septum. And the ends of the Purkinje fibers will penetrate about 1/3 into the ventricle musculature. All of this only takes about 0.03 seconds. See, 0.03 seconds was the time required for the SA node, the impulse from the SA node to reach the AV node. That is the same time it takes for all the fibers of the Purkinje fibers to get stimulated and transmit the impulse to all the endocardium of the ventricles. Only 0.0. Another 0.03 seconds will be taken for the impulse to travel from the endocardium to the epicardium. So the cardiac muscle wraps around the heart in a double spiral fashion. So this is how it is there. The endocardial fibers are traveling obliquely, and opposite to that the epicardial fibers are traveling, and there is a fibrous septa in between. So for the impulses to travel from the endocardium to the epicardium, the angulation, it takes a much more time. Because of the angulation, the transmission of impulses from the endocardium to the epicardium requires another 0.03 seconds. So the transmission of cardiac impulse SA node to AV node 0.3. Then there is an AV nodal delay of 0.13 seconds, which will be the transitional fiber, the AV nodal, the bundle of His, and the right and left bundle branches. Then it will take about 0.03 for the Purkinje fibers. So this is almost instantaneous. All the ventricular musculature is getting stimulated simultaneously so that contraction can happen synchronously. So 0. 0.9. So 0.16 to 0.19 for the endocardium to get stimulated, and then again 0.03 to 0.22 for the epicardium to get stimulated. And there will be atrioventricular fibrous tissue in between so that the impulses cannot transmit from the atria to the ventricle directly. So now we come to the pacemaker of the heart. The pacemaker of the heart will be SA node, which is the normal pacemaker. Why is that? It is because the SA node intrinsic rate of discharge of SA node is much faster than AV nodal or the Purkinje fiber. For example, the AV nodal fibers are discharging at a rate of 60 per minute. So if they're discharging at a rate of 60 per minute, so one discharge or one action potential will be generated in AV node every 1 second. But the SC nodal fibers are discharging at a much higher rate, for example, 80 beats per minute. So which is much lesser than the 1 second gap between two discharges. So when the SC node fibers discharge, they will send the impulse to the AV nodal fibers, and then the AV nodal fibers will reach the action potential because of the SC nodal discharge, or the impulse which is coming from the SC node. They will discharge, then they will go into a refractory period, which will be every 1 second another intrinsic discharge will happen in AV node. But before that 1 second period is gone, another SC nodal discharge comes, which will stimulate the AV node. Waiting for that 1 second, another SC nodal discharge. So because the SC node is discharge rate is faster than the AV node, and AV node is faster than the Purkinje fibers, normal pacemaker or all the impulses which are generated will be generated from the SC node, and then they are transmitted to the AV node and Purkinje fibers, and the ventricles also contract at this rate. So this is how or why the SC node is the normal pacemaker. Now, because of any reason, any pathology, anywhere else in the heart, even in the contractile tissue, if the intrinsic rate of discharge becomes more than the SC node, they will take over the role of pacemaker, and it will be known as ectopic pacemaker. See, because the pacemaker activity of the heart is not dependent on what is discharging. It is only dependent on which portion of the heart is discharging at the fastest rate. That will overcome all the other portions of the heart which are intrinsically discharging. So a pacemaker elsewhere then the SC node is known as an ectopic pacemaker or an abnormal pacemaker. This can be any portion of the heart which develops a discharge rate greater than SC node, or if the impulse is blocked from the SC node. If there is no impulse transmission from the SC node, if there is any blockade or if there is any pathology of the SC node, infarction in the SC node area, then the second best thing would take over the discharge rate. So AV nodal fibers will then become the pacemaker, or if the AV nodal are also blocked, then Purkinje fibers will take over the pacemaker activity of the heart. So the blockage of any transmission of cardiac impulse from SC node to other parts, anything else can become a pacemaker, which will be known as the ectopic pacemaker. So then what is the control of activity on the SC node and the AV node and the other conduction systems? So autonomic control will be there. There will be effect of potassium, calcium, and the effect of heat. These four things we'll be discussing now. So the autonomic control, as we all know, is parasympathetic nerves and the sympathetic nerves. Even though the heart is able to pump or rhythmically discharge without any external nervous input, still the autonomic nervous system will regulate the activity of the heart. Whenever they want to increase the heart rate or decrease the heart rate, then autonomic control can happen. So the parasympathetic nerves via the vagus are mainly distributed to the SC node and the AV node, a very less extent to the atria, but almost no parasympathetic innervation is there in the ventricular musculature. So the parasympathetic nerves will mainly be distributed to the SC node and the AV node. The sympathetic nerves are distributed to all the parts. So as opposed to the parasympathetic, sympathetic will be distributed to the SC node, AV node, the atrial musculature, and the ventricular musculature. So now, if there is parasympathetic stimulation, it will lead to release of acetylcholine. That acetylcholine will increase the permeability of potassium ions. If the permeability of potassium ions increases, what will happen? There will be increased efflux of potassium because of the concentration gradient. Increased efflux of the potassium will lead to hyperpolarization or decreased excitability of the heart. Increased efflux of potassium, the membrane potential will become more negative. If the membrane potential becomes more negative, it is hyperpolarized, and then hyperpolarized, it is decreasing the excitability. And where is the parasympathetic innervation? Mainly to the SA node and the AV node. So if the excitability of the SA node is decreased, there will be decreased rate and rhythm of the SA node, and there will be decreased excitability of the junctional fibers and AV nodes also. So the conduction velocity will also decrease, and the rate of SA node will also decrease. Second, if there is maximal parasympathetic stimulation, the force of contraction can decrease by 20 to 30%, but this is not a very major role of parasympathetic system because the innervation is not that much to the ventricles. Mainly the atria force of contraction might decrease by 20 to 30%, but the ventricles will not be affected that much. And coming to phenomena which is known as ventricular escape. So ventricular escape, when does it happen? It happens when there is a complete blockage of transmission from the atria to the ventricle through an AV node. As we already saw that ectopic pacemaker can happen if if any other portion of the heart is discharging much more than the SA node, or if there is any blockage of transmission from the SA node to the AV node. So if there is complete blockage of transmission from the atria to the ventricle due to either a strong parasympathetic stimulation. See, as we saw, if there is a strong parasympathetic stimulation, there is decrease in the excitability of the junctional fibers and the conduction velocity will decrease. If there is a strong parasympathetic stimulation, it can completely block the transmission of impulses from SA node to the AV node. Or in Stokes-Adams syndrome, there is partial ischemia of the conduction pathway or the internodal pathways. That can also lead to complete blockage of transmission. What will happen is, if there is complete blockage of transmission, the ventricles will stop beating for 5 to 30 seconds. Why does that happen? Because now there is no impulse which is coming from the SA node. If there is no impulse coming from the SA node, the ventricles will stop beating for about 5 to 30 seconds. And after 5 to 30 seconds, the intrinsic activity of the Purkinje fibers, which will fire at the rate of, what is the Purkinje rate? Purkinje will fire at the rate of 5 to 40 per minute. So even though no impulses are coming from the SA node or the AV node, the Purkinje cells or the Purkinje fibers still have an intrinsic ability to fire at a rate of 15 to 40. So the Purkinje fibers will begin to discharge rhythmically at their natural rate of 15 to 40, and they will become the ectopic pacemaker. So the ventricles will escape from the strong parasympathetic stimulation or complete blockage of transmission from the atria to the ventricle, which is known as ventricular escape. Now, why did the ventricle stop beating for 5 to 30 seconds in the first place? This is because of overdrive suppression. Overdrive suppression is the ventricular excitability is suppressed because the ventricles have been driven by the atria at a very high rate. Ventricle have been driven by the atria at a rate of 70 to 80 beats per minute for almost always. So because of that, there is an overdrive suppression, and the ventricle's intrinsic or the natural rate has been suppressed always. When there is no transmission from the SA node or the AV node, it takes about 5 to 30 seconds for the Purkinje fibers to start discharging rhythmically at their natural rate, and they will escape the blockage of the transmission or the strong parasympathetic stimulation, which is known as ventricular escape. Second important thing is, because the ventricles stop beating for 5 to 30 seconds, the blood supply to the brain is also lost. Within 5 to 10 seconds of loss to blood supply to the brain, there will be fainting or syncope episode. So in patients of Stokes-Adams syndrome, because of this repeated blockage of the transmission, because of that partial ischemia in the internodal pathways, there will be repeated attacks of fainting or syncope, which will be happening. The patient will present with symptoms of repeated attacks of fainting or syncope. So this is the concept of ventricular escape. Now, after parasympathetic, coming to sympathetic, a stimulation of sympathetic nerves releases norepinephrine. Norepinephrine will act on the beta adrenergic receptors, and those beta adrenergic receptors will increase the permeability of sodium and calcium ions. Increasing this will increase the excitability, so increase rate of SA node can increase up to 180 to 200 beats per minute. A strong parasympathetic stimulation can almost stop the heart rate or stop the heart, and a strong sympathetic stimulation can even increase the rate of SA node to up to 250 beats per minute. It will increase the rate of conduction in the internodal pathways and the Purkinje fibers. And also, because the sympathetic fibers are innervating the ventricular musculature and there is increased permeability of calcium ions, the force of contraction of cardiac muscles will also increase. It may even double. Second important thing is that there is always, we know that there is always a vagal tone, a parasympathetic tone which is present, but there is also a continuous sympathetic discharge also which is present, which increases the cardiac output up to 30%. So if we can see on the x-axis there is the right atrial pressure and the y-axis there is cardiac output. So if there is normal sympathetic stimulation and if there is zero sympathetic stimulation, there is about 30% difference between the cardiac output. Even at zero right atrial pressure, if we see, there is a 30% difference in the cardiac output which is there, and this is the maximal cardiac output which is there. If maximal sympathetic stimulation is there, it can increase the cardiac output up to 4 to 5 times of the normal. And if parasympathetic stimulation is there, it will decrease the cardiac output. So this is how autonomic control of the heart is present. Then effect of potassium. The effect of potassium is high extracellular potassium will partially depolarize the cell membrane. Just as we saw in parasympathetic stimulation, there was increased permeability of potassium, which increased the efflux of potassium, decreasing the resting membrane potential or the membrane potential to more negative value, which was hyperpolarization. If there is high extracellular potassium, what will happen is there will be decreased efflux of potassium, which will increase the membrane potential, increasing the membrane potential or partially depolarizing the cell membrane or making it less negative. Then because of the partial depolarization, the intensity of action potential decreases. The intensity of action potential is decreasing, which decreases the heart rate. So hyperkalemia will decrease the heart rate, decrease conduction velocity, and decrease the force of contraction. So this is the effect of potassium. The effect of calcium would be opposite. If there is high extracellular calcium, what will happen? There will be increased efflux of the calcium inside the muscles through L-type calcium channels which are present in the T tubules because of the concentration gradient. And as we know that the excitation contraction coupling or the contraction of muscles in the cardiac muscle is mainly dependent on the calcium which is present in the extracellular fluid, because the sarcoplasmic reticulum of the cardiac muscle is not that well developed. So increased influx of the calcium from the extracellular space will lead to increase in the force of contraction and can even lead to spasticity. This is the effect of calcium. Now last, coming into the effect of temperature. If there is increased body temperature, it increases the permeability of ions. So increased sodium and increased calcium influx will be there. And as we all know that increased temperature will lead to increased metabolism in all the tissues of the body. So that increased rate of metabolism also increases the excitability in the SA node. So SA node also has an increased rate of metabolism, increasing the excitability. What will happen? This will increase the heart rate or the rate of contraction and also increases the force of contraction. The heart rate will increase 10 beats per minute for every 1 degree rise in Fahrenheit from the normal body temperature, or 18 beats per minute for every 1 degree rise in Celsius from the normal body temperature. But it will happen only till a certain amount. So beyond 105 degrees Fahrenheit. So let's say the heart rate has increased about 70 beats per minute from 98 degree Fahrenheit to 105 degree Fahrenheit. After that, because of the high temperature, there will be progressive weakness of the heart muscle, which will eventually lead to decrease in the heart rate. Same will happen for the contraction. If the force of contraction increases with increasing temperature, but prolonged elevation will lead to exhaustion of all the metabolic systems. So all the metabolic system will get exhausted, which will lead to weakening of the heart and decrease the force of contraction. Similar process happen in heart rate and force of contraction. This is very important when we are considering the effect of fever in increasing the heart rate, or if during exercise there is increased body temperature during exercise, because there is increased rate of metabolism in the muscles, there is increased heat production. That increased heat production can aid in increasing the force of contraction and the heart rate and increasing the cardiac output, which is required to sustain the increased muscular activity or maximal effort of the exercise. So that is the application of increased temperature or the effect of temperature on heart. So in this lecture, what did we discuss? We discussed how action potential is generated in the ventricular musculature. How is that different than in SA node? Why is there a self-excitation ability in the SA node? Then we discussed about the conduction pathways, and at the end, the effect of autonomic system, the effect of increased potassium, increased calcium, or increased temperature on the excitable and the conducting system of the heart. This lecture will form the basics of the ECG lecture, in which we will be discussing about the PQRST waves and what are the bases of these waves, and how is the dipole or the depolarization wave traveling from SA node to the AV node and to the ventricular musculature and depolarizing, and then eventually repolarization will happen during the relaxation phase. So thank you for watching this video. If you have any doubts, you can contact us on any of these social media, or you can put the comments in this YouTube video also. Thank you. We will try to upload videos regularly.